I am Bob Kanar. I'm the CEO for Mediri Therapeutics. We have two distinguished gentlemen this evening who will be speaking on behalf of Stretta. Our first speaker is Dr. Nirav Tassani. He is the chair of gastroenterology and the director of advanced therapeutic endoscopy at Ertan Digestive Disease Center at Memorial Hermann in Houston, Texas. And following him will be Dr. Samer Matar. He's a professor of surgery and chief of bariatric services at Oregon Health Sciences University in Portland, Oregon. So without further ado, Dr. Tassani. Thank you.
Thank you, Bob, and good evening, everyone. So I'm a gastroenterologist. I work for University of Texas and work very, very closely with my surgical colleagues, and so always fun to present gastroenterologist perspective in front of all of you. We'll start in 1 minute as soon as I can figure out how this works.
Is there a green button?
Yeah.
Don't
all
ask
right.
me to figure it out.
So today, I know most of you are familiar with what Stretta procedure is, but we will briefly go over what Stretta is and how it works, what is the mechanism of action. We'll also talk about 2017 meta-analysis and what is the most current evidence for Stretta. I will also give you an idea from what is our American Society of GI Endoscopy and what is their perspective. I'm one of their technology committee members, and I drafted our ASG guidelines on endoscopic anti-reflux devices. So this is about to be released, but so I will give you our experience and our take. And lastly, at our center, mainly I'll share with you that in which patient population Stretta fits and which patient we do offer Stretta. So without further ado, can we start the video? So Stretta is one of the minimally invasive endoscopy surgery for treatment of reflux. In this procedure, very low dose radiofrequency energy is applied to lower esophageal sphincter. It has a 4 antegrade treatment level, and which is applied just in and around GE junction, and 2 retrograde treatment levels. And because of this treatment, eventually it results in significant increase in the thickness of lower esophageal sphincter muscle. So there are very well done studies. This was the first study done by Dr. Kim that showed in the canine model, after application of Stretta, is a significant increase in the size of smooth muscle. It increases in thickness as well as number. And so they showed in canine model there was more than 50% increase in the thickness of GE junction. There is also well done human data. The image you see on the left hand side, this is on the rectal muscle, where they showed significant increase in the size of the rectal muscle. And subsequent images, these are the endoscopic ultrasound images. These are the images of actually lower esophageal sphincter muscle. And this is post 3 month Stretta, where they were able to demonstrate on endoscopic ultrasound increase in the thickness of lower esophageal sphincter muscle. So when that happens, this leads to decreased GE junction compliance without any fibrosis, and it also decreases transient lower esophageal sphincter relaxation. And we all know this lower esophageal sphincter relaxation is one of the key feature of reflux, and once that is reduced, we can help patient with reflux. Before a recent study, this was the prior evidence. Dr. Perry had done a very nice meta-analysis in 2012, where he included 18 studies with over 1,400 patients, and they looked at various subjective as well as objective measures, and they were able to show improvement in all different measures that included GERD-related quality of life, PPI use, patient satisfaction score, but also they were able to show significant improvement in objective parameters such as esophageal acid exposure, Demister score, and lower esophageal sphincter pressure. So now we will talk about most recent meta-analysis. This meta-analysis was done by Dr. Ron Ifas, and their aim was to determine efficacy of Stretta in treatment of GERD. The key difference compared to last meta-analysis, this meta-analysis included 28 studies and it had more than 2,400 patients. Also, one of the key features is prior meta-analysis included all retrospective studies, prospective studies, randomized control trial. Compared to that, this meta-analysis mainly focused on randomized control trials and prospective studies. So this had 4 randomized control trial. It included 23 prospective cohort studies and 1 prospective registry. Here, the key objective for this meta-analysis was subjective features which matters to the patient, which includes GERD-related quality of life, heartburn score, and PPI use. Somewhat the gray line between subjective and objective is the rate of erosive esophagitis, and true objective parameters such as esophageal acid exposure and lower esophageal sphincter pressure. So let's look at one by one. So first is GERD-related symptom relief or quality of life. For this, they included 2 randomized control trial and 9 cohort studies, and they had more than 500 patients. So as you can see in the forest plot, here, if you just include randomized control trial, there was a significant reduction in the overall score. So that means a patient reported significant improvement in GERD-related quality of life symptoms. When you combine all studies, all randomized trials as well as prospective trials, again, there was a sustained significant improvement in GERD symptom score. Now we'll move to heartburn score. Again, for this, 13 studies, 2 randomized control trial and 11 cohort studies were included. There were more than 1,100 patients in this thing. And again, here, if you look at just randomized control trial, this did not reach statistical significance. However, it's important to know these randomized control trials were not looking at heartburn score as a primary objective. So it was not designed to look at any improvement in heartburn score. Both had a very different duration of follow-up. One had only 3-month follow-up, one had more than a year of follow-up. But when you combine all the data, then you can again see significant improvement in the heartburn score, and which is statistically significant. Now moving on to rate of erosive esophagitis. This also included more than 400 patients, and as you see here, total, there was a significant decrease in the risk ratio. So here risk ratio is 0.064. What it means is that 36% improvement in rate of erosive esophagitis on follow-up endoscopies. Now moving on to proton pump inhibitor use, which as my perspective matters most to my patient, their heartburn score and PPI use, because they want to get off the PPI. So in this meta-analysis, there were 23 studies, more than 1,700 patients, and 97% of patients were on PPI at baseline. And after Stretta treatment, as you can see in this forest plot, overall risk ratio was 0.49, which was statistically significant. What it means is 51% of patients were off PPI during their follow-up. And now we'll look at some of the objective parameter. So one of the most important objective parameter is esophageal acid exposure. Here what we are trying to measure is percentage of total time where pH was less than 4. And for this meta-analysis, again, significant improvement in esophageal acid exposure was noted. And same thing we can look at by means of Demister score. So if you look at Demister score, there was also significant reduction in Demister score. So Demister score on an average improved by 13 to 14 points, so which is a significant reduction in Demister score compared to baseline. And finally, we look at the last parameter, which is lower esophageal sphincter pressure. Here, you can see that there was an improvement, but this did not reach statistical significance. It is important to note that there are only 269 patients. So out of all the studies, most studies were actually not looking at this parameter. And if this almost reached statistical significance. There is trend toward it, but because of low numbers, right now in this current meta-analysis, it did not reach statistical significance. So this is the summary of this meta-analysis, or any key takeaway from this meta-analysis. So with Stretta, there is significant improvement, 32% improvement in acid exposure time, 36% reduction in rate of erosive esophagitis, more than 58% improvement in heartburn score, also about 60% improvement in GERD-related quality of life score, and 51% reduction in use of proton pump inhibitor therapy. This meta-analysis further went on, and from all the studies, they also looked at overall adverse effect or safety of this procedure. So total, there were about 2,400 patients who had a Stretta treatment, 52 had a sham treatment, and 195 had a laparoscopic fundoplication in all the studies that were included in this meta-analysis. What they found was rate of adverse event was close to 1% for Stretta and about 7% for laparoscopic fundoplication. Most common adverse events were mucosal erosion or laceration, and in the laparoscopic fundoplication, subcutaneous emphysema was the most common reported adverse event. So as you can see, adverse event 1% is very, very low, and also majority of adverse events are very, very minor, that mucosal laceration or erosions. Now moving on to our ASG society. So our American Society of GI Endoscopy has more than 14,000 members. Before attending this conference, I never realized how big SAGES was, but even this conference is massive. It's a huge, huge conference. So we have a technology committee which is comprised of 15 members, and our task is critically evaluate any given technology. So usually 1 or 2 persons are assigned to critically review this thing. About 1.5 years ago, I was given the task to review all the literature related to endoscopic anti-reflux procedures. So that included Stretta, TIFF, Muse, and this draft so far has gone about 35 revisions. So after you draft it, it goes one after another, multiple different experts, including surgical experts, and before it goes through final approval. What I can tell you, this was our take for Stretta. So what we say this thing is, endoscopic anti-reflux procedure offers minimally invasive option for select patient with reflux, not controlled by PPI, and with randomized control trials showing improvement in patient-oriented outcomes, such as GERD-related quality of life score and ability to decrease or discontinue acid suppressive medication. So this is our final take on Stretta treatment. We also had our guideline committee write our guidelines, and what they say is that Stretta technique appears to be durably relieve reflux symptoms for up to 10 years in majority of the patients, and our ASG society suggests that endoscopic anti-reflux therapy should be considered for selected patients with uncomplicated reflux after careful discussion with the patient regarding potential adverse events, benefits, and other options. So now we'll give you where Stretta fits in my practice. So this is our endo center. We are about 18 gastroenterologists, and 7 of us are advanced endoscopists who perform these procedures. So this is the patient who comes to your clinic, and he says, I quit smoking, I quit drinking, I take PPI every day. It helps, but still I continue to have troublesome reflux symptoms. So the reflux symptoms which are responsive to PPI, but patients still have breakthrough symptoms despite taking daily PPI, then for this patient we will recommend considering some of the endoscopic anti-reflux procedures. In other contrast, you have a young female come to your clinic, and she says she has daily reflux symptoms. She takes PPI. On PPI, symptoms are well controlled, but now she has a terrible side effects of a PPI treatment, and she is very worried that she is too young and she has all the PPI side effects, and so she wants to get off the PPI. So these are the ones also. When there is a serious side effects or concern for serious side effect for PPI, then we would consider use of Stretta treatment. And finally, if this gentleman comes to your office and you do endoscopy, you actually find a complication of reflux, such as here you see Barrett's. Also, you see this small early esophageal adenocarcinoma, which you can treat endoscopically and fix it. So this is actually one of our patients where we found esophageal cancer, we treated it, we treated Barrett's by application of radiofrequency energy, but that comes a big question, are we going to stop it now or fix the real problem which started all these things? So in our practice, patient who develop serious side effects because of reflux, whether it's erosive esophagitis, stricture, Barrett's, after fixing those, we do consider some of the real option to fix the reflux symptoms. And that's my take. So thank you.
Dr. Samer Matar.
Thank you. Thank you for Mederi for inviting us to speak. And I was asked to give the surgeon's perspective of this coin about Stretta therapy for GERD, and focus not only from the surgeon's perspective, but also on special populations that we see as surgeons. Let me tell you a little bit about myself. I run the bariatric program at Oregon. I've been doing bariatrics for nearly 20 years. And because we're a university, we tend to get referred patients who are very complex occasionally, and many of them do complain of very troublesome GERD, and they represent a complex subpopulation to treat. So I like the slide because it shows you where Stretta fits in the continuum of care that we have, that we can offer our patients. As Dr. Thusani elegantly described, we can give PPIs to the majority of the patients, and we do as a first-line treatment. And as surgeons, what we love to do is offer everybody surgery, of course. But that is not conceivable nor actually realistic. And there will be patients who are either not candidates for surgery or who've had surgery and have persisting GERD. And there are patients also who've had bariatric surgery, which is itself supposed to be an anti-reflux operation. Even the sleeve is supposed to improve GERD. And so there are a subpopulation of these patients who continue to have persistent GERD or develop de novo GERD. And, you know, although the gastric bypass is considered to be the ultimate or the gold standard, the best anti-reflux operation, we never reported 100% improvement in GERD. Even in the best hands, we have maybe 70% resolution of GERD. And of these remaining 30% of patients who have persistent GERD, there may be 5 or more % of patients who have refractory GERD to medical treatment. And those, of course, are the ones that we have to help. So in general, Stretta fits in those patients that I mentioned. Also, it's important to not include patients who have large hiatus hernias because of the technical complexity or difficulties that results in. It's preferable to apply this to patients with mild to moderate GERD and those that have had partial response. So once again, the Stretta is a very favorable, if you want, option for patients with GERD for many reasons, and I'll get into that. But always remember that bariatric surgery does not resolve GERD in 100% of patients. You're always going to be faced with patients who have either persistent or de novo GERD that require treatment, and those that are refractory to medical treatment, then you should probably consider Stretta, because they don't have a lot of options. As you know, patients who've had Roux-en-Y gastric bypass, you can't offer them innocent fundoplication or any other kind of anti-reflux operation. Patients who've had sleeve, yes, you can offer to convert them from a sleeve to a gastric bypass, but they received the sleeve for a reason in the first place. As Dr. Pleitman told me earlier today, these patients never wanted a gastric bypass in the first place. Plus, you have to consider the additional high risk and complexity of converting these patients from one operation to the other for the purpose of treating GERD. And so these are patients who can potentially benefit dramatically from a non-invasive procedure such as Stretta. And here is very nicely listed the reasons why Stretta is favorable in this particular population. It's a non-surgical procedure. It's delivered transorally, and it's especially favorable for patients who've had prior surgery. Patients with GERD after Roux-en-Y gastric bypass, as I mentioned, now have an option for relief, whereas before it, they didn't have any surgical options. And patients with de novo GERD after sleeve gastrectomy can avoid, as I mentioned, the more invasive and technically complex gastric bypass. And you don't burn any bridges. If it doesn't work, then you can still pursue other options, more invasive options. And as mentioned earlier, it can be repeated without any adverse effects. I actually looked into this back when I was in Pittsburgh some years ago now. I had a group of patients who were bitterly complaining of severe GERD, and they had reached the maximum allowable PPIs, double dose PPIs, ranitidine at night, and antacids, and they were still having troublesome GERD, aspiration, dysphagia, you name it. And so we decided to offer these patients Stretta, and we actually objectively studied them with pH studies before and after treatment. The follow-up pH studies were performed 3 months after surgery, and you can see how in these 7 patients, that was our series, how it significantly reduced the Meester scores, and also this correlated with improvement in their quality of life scores. This is another study. This comes from Duke, where they applied Stretta not to gastric bypass patients, but to sleeve patients. And again, this is a very difficult population to treat, but with Stretta, they were able to achieve symptom-free status in 2 patients at 8 months, and another 2 patients had significantly improved their GERD symptoms and were managed with reduced medication use. And importantly, in this group of patients, there were no adverse effects, no complications. In fact, this pilot, if you will, study was the seed for a multi-institutional study that's just been started. And this includes 10 sites. The lead site is Montefiore, and the planned enrollment of patients is 80. And the follow-up will be at 12 and 24 months, and there will be both subjective and objective parameters that are going to be studied in these patients, and we're all anxiously, excitedly waiting for the results of that study. This is a study from here in the United States where Stretta was applied for patients after anti-reflux surgery, not bariatric surgery. And these patients had received laparoscopic Nissen fundoplications. There were about 100 patients, 18 of whom had laparoscopic Nissen fundoplication. And the idea was to compare that sub-cohort of patients with other patients who were receiving Stretta for the typical symptoms of GERD. And they found that in this population, there was no significant difference in the quality of life scores, and satisfaction increased in both groups, and the medication scores decreased in both groups equally, meaning that there was no harm, or there should be no limitations in offering this therapy to patients after anti-reflux surgery. This is another study from McCluskey and Lena, who I think was she's left. And this comes from Emory, where patients were assessed who had recurrent reflux after anti-reflux surgery, recurrent GERD. And they found that they were able to achieve marked improvement, significant improvement in 85% of those patients. And they concluded that Stretta may serve to help manage recurrent GERD after anti-reflux surgery. Now, I was asked to also focus on this clinical spotlight review that was recently published by SAGES. This is similar to the ASGE position statement. This is a document that is the result of a careful search and study of the published literature thus far with a view to answering these four main questions. And I will go by each one individually. So the study was intended to indicate preferable approaches to medical problems in general. It's based on existing data or on consensus of expert opinion. And it was developed under SAGES. It was revised several times by the members of the committee, and then it had to be approved by the Board of Governors. And as you can see there, it was extensively researched and reviewed. So the methodology for answering the questions included a systematic literature search, two SAGES guideline committee members who then selected the papers, and they graded them for quality of evidence and strength of recommendation according to the system on that slide. So in terms of question one, in primary or post-surgical GERD, how does Stretta compare with continued medical treatment or anti-reflux surgery for symptom control, resolution, or recurrence? And the answer was that compared to fundoplication, the Stretta, although was slightly less effective for GERD symptoms, it has been used effectively after prior anti-reflux surgery with promising results, and also after bariatric surgery. It is important to remember to use Stretta for patients who have hiatus hernias less than 2 centimeters in size, and also the Stretta improved the majority of GERD indices. Even though it might not normalize and bring pH levels back to normal, the patients in general significantly improved their symptoms, had improvement in their symptoms. So how safe is Stretta? Well, it's interesting that in all the meta-analysis it showed that the incidence of adverse events was less than 1%. And the FDA MDR completion rate since the year 2000, that's nearly 17 years now, in 20,000 procedures was also less than 1%. And it is notable that both the meta-analysis and the FDA findings were equivalent. It is important also to note that there was a learning curve or an evolution in the technology such that the majority of adverse events occurred remotely in the early life of this technology, and now it's basically zero. Question number 3, how does the comparative effectiveness of Stretta change with longer follow-up duration? In other words, how durable is this treatment? What's the amount of decay that can happen over time? And it's been shown that it's durable up to 10 years. That's what we have data for. Multiple studies are available that followed patients beyond the first year. And you can see there that both when in comparative studies, for example, with LAB2P, both groups achieved similar independence from PPI treatment at 3 years follow-up. And all studies with follow-up more than 4 years indicate that effectiveness persists in the long terms, even though the degree of effect might erode over time. Question number 4, how does the comparative effectiveness of Stretta differ based on the surgeon's experience? And this has not been studied in great detail. In terms of time taken to complete Stretta, the reporting learning curve appears to be 5 cases or less. I can tell you in my experience, it is an easy learning curve to scale, and most of the practitioners that I ask agree that it is not a technically complex or challenging procedure to master. So finally, the SAGES CSR, it concluded a strong grade recommendation. concluded that Stretta significantly improves health of quality life scores, heartburn scores, incidence of esophagitis, and esophageal acid exposure. It decreased significantly the use of PPIs with all its attendant long-term complications and side effects. The effectiveness of the procedure does decrease over time, but persistent effects have been described up to 10 years after application. And of course, it's more effective than PPIs, but less so than fundoplication, again reinforcing the position of Stretta in the middle, as a middle therapy between PPIs and fundoplication in terms of efficacy. What's important is that it is safe, it has a short learning curve, it has very low adverse effects, and it's effective and repeatable. And the level of evidence at the end of the day is 3 pluses, and it gave a strong recommendation for it. So just to recap, Stretta fills an unmet need. In patients who are either intolerant or don't respond to PPIs or don't wish to continue on PPIs, like the Beauty and the Beast. Patients who don't wish to have surgery or an implant, and I'm talking about the magnetic beads that are available that you have to operate, and usually operated upon stomach. And these are the other indications, and most importantly, in my case, post-Nissen patients with recurring reflux and post-gastric sleeve and bypass patients. I'd like to, and contraindications, of course. This is not approved for children or pregnant women. You need to have a diagnosis of reflux. And again, do not apply this to patients with known hiatus hernias, especially large ones. It's not applicable to patients with achalasia. And those who, in my case, I like to offer patients general anesthetic and I intubate them. And those patients who are not candidates for that are obviously poor surgical candidates and should probably continue on PPIs. I do post this picture with the patient's permission. She was so excited, and when I saw her at follow-up 3 months after her GERD, her Nissen fundoplication. Let me tell you a little bit about her, introduce her. She is 57 years old. She had gastric bypass 7 years ago. She developed GERD, and she had severe GERD to the point that she was aspirating continuously. She'd had at least 10 hospitalizations for aspiration pneumonia. She was miserable. And she was already on the maximum medical therapy that we could think of. And we offered Stretta. And 3 months later, she is symptom-free. And she's happy and smiling and giving me a hug. So I'd like to conclude by reminding you that we have a lot of data supporting Stretta, 25,000 procedures, 17 years. There are more than 40 studies that concluded its safety and efficacy. We have long-term follow-up, 4, 8, 10 years and more. We have over 3,000 patients who were studied in clinical trials. We have level 1 evidence. We have society support from 2 of the largest surgical and gastroendoscopic societies. And data shows versatility in both application and indications for this technology. Thank you very much.